here. The first is to remember that many patients do great after the ICU. We're going to talk about the problems because the problems are things we're going to fix. But the fact that there are problems doesn't mean that most people don't do great. This is some old data from Brian Cuthbertson that pointed out that at 5 years following up a Scottish group, and maybe the Scots just don't complain, but all patients who stated they would be willing to be treated in the ICU again, 81% did not have unpleasant memories of the ICU, and 80% were either very happy or mostly happy with their quality of life. On the whole, critical care medicine is imperfect, but provides extraordinary benefits to patients. Nonetheless, we used to imagine that we were flawless healers. And in 2004, Gordon Barnard gave an interview. This was right after the Prowess trial. And at this point, Gordon Barnard is probably the single best informed trialist in the United States. And I use this quote not to in any way denigrate the extraordinariness of Gordon Barnard's contributions to critical care medicine, but actually to say that he literally embodies the state of the art at the time. And that was only 16 years ago. And for the internal medicine residents in the group, 16 years ago seems like an eternity. But for those of us who are a little older, it wasn't that long ago. And Dr. Barnard was asked, is there a residue in sepsis survivors who've had multi-organ failures or dysfunction? And in brief, he says no. He says most people return to normal or near normal lives, even if they've had severe organ failures. Persistent problems are rare. Most surviving patients come back to being normal. And unfortunately, Dr. Barnard's wrong. That the evidence that's accrued in the decades since this optimistic take suggests that persistent problems are really quite common, and that a lot of folks have to find a new normal. They don't get back to who they were. They can, Phoenix-like, become something different that has grown, but it's not the same. We know, for example, from my brilliant colleague Hallie Prescott's work, that there's ongoing excess mortality for at least 2 years after severe sepsis. And let me just take you through this graph. So what this is this is a cohort of about 1,000 elderly patients, and where they are is starting a discharge after severe sepsis is graphed each day. The x-axis goes from 0 out to 12 months, and there's 1 pixel width per day. And what you can see is, in the first 90 days after severe sepsis, there are a lot of people who are in healthcare facilities. That number falls off precipitously at about day 100, which is probably not a coincidence, given that these are largely Medicare beneficiaries. We see that lots of people spend a lot of time at home, but also that among patients who are discharged alive with severe sepsis, more than a quarter are going to go on to die in the year afterwards. So this is substantial and ongoing excess death among patients with severe sepsis. And COVID-19 ARDS is nothing if it's not severe sepsis. But even among those who survive, we know there are other problems. We know there's a complex web that's been a subject of enormous investigation for about 2 decades. And let me start how I think about this set. Broadly, this goes under the name of the post-intensive care syndrome. I find it useful to teach it slightly different than the classical post-intensive care syndrome. I hope Dr. Dale Needham at Hopkins will forgive me, but this is how I think about it. It begins with a patient, and this isn't just sort of some kind of trite Oslerian wannabe. Nothing about critical illness or nothing about medical critical illness is going to make you better than you were beforehand. So to understand what happens to a patient afterwards, you have to understand the cluster of medical comorbidities as well as socioeconomic dislocations that the patient faced beforehand. Then they become acutely ill. They become inflamed, they're hyperperfused, they develop new organ dysfunctions, they develop muscle weakness, they have altered thirst and hunger. And because they would die after otherwise, we put them in a bed and we subject them to the hazards of hospitalization. Now, those hazards aren't isn't us being capricious. It's not us hurting patients. It's because our art is imperfect. And so, in order to give them life saving medicines, we have to do invasive lines procedures. We give them 20 liters of fluid in, and then we take 25 liters of fluid out with diuretics. We put them on a barely edible diet and frequently make them NPO. We leave them immobilized. We stop the medications they were on beforehand. We give them a huge number of sedating medications. We deprive them of sleep. And even in the days before COVID-19, we socially isolated them. And among the most heartbreaking parts of our last few months' practice has been seeing the profound social isolation of our ICU patients, COVID or not, in this modern era of infection control. And then a host of things happen to them. They become malnourished. They develop volume depletion. Sometimes they manage to be intravascular volume deplete while at the same time carrying 20 pounds of extra fluid. They develop iatrogenic infections and delirium and deconditioning and falls and syncope. And their families are isolated and develop the family intensive care unit syndrome. The exact webs of arrows here are not sufficiently studied, and this is an active area of ongoing investigation. But we know is that there are four proximal outcomes that happen to patients. That consistently they develop new or worse organ failures, they develop weakness, they develop cognitive impairment, and they develop psychological problems. And while those sound like patient-centered outcomes, I'm going to contend they're not. They're actually the proximal medical targets that we can manage, and they're going to inform the rest of this talk. But the real patient-centered outcomes is that we know these patients are more likely to die for at least 2 years afterwards. They're unable to return to their social roles often. They have recurrent health problems that bring them in and out of the healthcare system and in and out of the hospital. And all of that places an extraordinary burden on their caregivers. It's a lot. There's a lot going on, and there's a lot of, and this was in the best of times. In our previous times, what Elena Byhoff has called the before times, before our current surge. But we also know that good care is not always provided to them, but when it is, good follow-up care can actually improve outcomes. This is some data out of North Carolina where Stephanie Parks Taylor and a group looked at a cohort of about 130 sepsis survivors and asked how many of them got four care elements. Those care elements have all been embedded in the Dirty Dozen, so we'll talk about them later. But for now, just say four components of good post-sepsis care, and asked, what were the odds that this patient, after a risk adjustment, would be readmitted or die within the 90 days? And what they see is a nice dose response curve, where the more of those care elements you received, the less likely you were to die and the less likely you were to be readmitted. And moreover, that there's an extraordinary distribution. Only 20 of these patients actually, as I do the math there, more than 200 patients, only 20 of those patients got all four elements, and their risk of death or readmission was dropped by an order of magnitude. However, lots of other patients didn't get them. So good care can help. But when we think about what good care for these patients is, we go to the guidelines, right? And the Surviving Sepsis Campaign 2016 guidelines, the last major promulgation of this, all of you who are ICU fellows have sat down and read it, right? 67 pages of text, 655 references, 23 categories of recommendations for adults, and extensive discussions of the results of selenium, of whether we should doing carnitine supplementation, of something called blood purification, but there is zero discussion of any aspect of post-discharge care. Now that'll change in the 2020 guidelines, but it just talks about how little we've focused on post-discharge care as a part of the excellence of what it means to be a great ICU and a great critical care doc. And indeed, I worry some days that our current model is fundamentally about death preventing critical care. And don't get me wrong, not being dead is in the vast majority of times a noble and important goal. But much of my agenda and the agenda of some of these people in the call, certainly Dr. Audish has been an inspiration to me, is to ask what would recovery-focused critical care look like? If we were trying to not merely avoid death, but really help people heal, what would we do differently? And that brings me to the second part of our talk, which is let's try to avoid making silly mistakes. And so I want to go over in the next 20 minutes or so is the dirty dozen. These are 12 things that I have found that are mistakes that I've made, mistakes that my colleague made, uh, and uh, and they happen, and they happened before COVID. And my concern, and part of what prompted us to put this together, is that particularly in the COVID surge, we're all working faster. We're working harder than many of us have ever worked before in our lives, where many people are having to surge into unfamiliar role. Surgical intensivists are having to take care of medically ill patients. Hospitalists are running MICUs. Outpatient rheumatologists are running hospitalist services. It'd be useful to have a list that focuses on what are the avoidable errors. So this, if you do all 12 things here, you're not going to completely prevent post-intensive care syndrome. A lot of that damage is done if I blow out their left ventricular free wall, or they have kidney failure before they get um, into the post-intensive care syndrome. This isn't going to fix this. But what this can try to do is attend to the last day on service and those transitions to make sure that they're done well and carefully, and that we don't heap on any other avoidable damage on top of whatever unavoidable damage is there. The dirty dozen is going to come in 5 clusters. And the first cluster is the medication cluster. And so we got to ask, are their home meds restarted? Let me tell you an anecdote and show you some data. That anecdote is, I want you to introspect, and I will tell you my answer as to how long you need to be off norepinephrine and out of shock before I will kick you out of the ICU. I will tell you, under the standard bed pressures where I operate, 12 hours off norepinephrine and you are getting it put in for a floor bed if you do not have another indication. Now, I practice at the VA Ann Arbor as well as at the U. Many of our veterans are on 3, 4, maybe 5 antihypertensives. 12 hours after I stop norepinephrine is not the time to restart their atenolol and restart their ACE inhibitor and restart their Lasix and restart everything else. We'd kill them. So we appropriately do not restart all their home meds on ICU discharge. That's not a medication reconciliation failure. That's the fact that they don't have their vascular tone yet back after they're stable enough for us to push them to the floor. These with the bed pressures your institution, my institution is facing, these kind of discharge pressures have been even more aggressive. So lots of meds don't get restarted on ICU discharge. And you can imagine that it's very easy to drop the ball afterwards. This is some data from Ontario showing just how often the ball is dropped. So in that middle column, you're looking at patients who had an ICU stay who were on the medication beforehand. And what you see is about 15% of patients who are on statins beforehand get them stopped and do not have them restarted. And I believe this was 6 months to a year afterwards. And hey, maybe that's right. Maybe 1 in 7 patients in Ontario should not have been on a statin and didn't need it. What I can tell you is that those numbers for the VA and some data that was about to come out in PLOS One sometime this week is a third. And I find it utterly implausible that a third of all veterans who come into the ICU on a statin should not be on a statin again. I find it plausible that a third of them have a transient reason for it to be stopped. We probably stop it more than we need to. But I do not believe that a third of them have such bad rhabdomyolysis or had a bad liver injury that they should not get it again for the year. And likewise, look at that levothyroxine line. 15% of patients who came in on levothyroxine went out without it. And again, I don't know what the rate of iatrogenic thyrotoxicosis in Toronto was in 2009, where this data are from, but I just don't believe that 15% of their patients are on were so thyrotoxic that they no longer needed any levothyroxine for a year afterwards. So thinking about careful medication and communication for the discharge plans when they're going home. The next piece is asking, if they've been restarted, have we retitrated them? Their blood pressures are different. Their blood pressure sugars are different. Their body weights are different. Their creatinines are often not anywhere back to their normal. And have they been titrated? This is the data from North Carolina that showed 1 in 5 patients did not have necessary medication dose adjustments based on creatinine or body weight changes. And honestly, it wouldn't shock me if this is true of my patients as well. I often don't run the med list on discharge. I just assume that the intern who may have picked up the service, 3, 4 hours ago, could just sort out which of these were intentional and which of these were not. And I've been trying to fix that. At the same time, we've got to ask the question of, do they need whatever antipsychotics, PPIs, H2 blockers, sleep aids, or opiates, or other medications we sent them out the door with? We give a lot of antipsychotics in the ICUs. A little less than we used to before the Mind USA trial, but it is not uncommon for people to end up on some Seroquel. And honestly, Seroquel is a great sleeping agent. It helps people get through the night. It helps avoid phone calls. That's not a good reason to be on long-term antipsychotics. But if we're not careful about the indication for these and whether they should be stopped on ICU discharge, think about the conundrum that the poor hospitalist who gets them is in. On the one hand, it's very likely that their patient coming out of the ICU didn't need that antipsychotic, and they should stop it for the good of the public health and the population. On the other hand, there is a small chance that they did need it. And if you're the hospitalist who stops all the antipsychotics, and as a result, as happened to Penn when I was there, one of your patients has a psychotic break and starts running down the hallway and has happened on Founders 12, jumps up on the table and pees on top of the nurses, it's not going to be a good call for you. So the risk for the hospitalist of making the decision to overrule the ICU and stop these drugs is substantial. And so it feels very important in the ICU that we are very clear about which of these medications we're starting for transient reasons. The Toronto data said about 2% of people get an antipsychotic, about 5% get a benzo. What I can tell you is for the VA and more recent data, between 10 and 15% of all patients who come out of the ICU who were not on an antipsychotic beforehand and who do not have any mental health diagnosis, nonetheless still get an antipsychotic afterwards. I'm very worried about the population health implications of all that Haldol and Remeron going out. The third piece that I think is COVID specific is that we have to ask, what's the plan for anticoagulation? I suspect in the Q&A we can have some vigorous discussion about whether what your group's practices have been for anticoagulation in patients with COVID. I can tell you at the University of Michigan, we have not developed a single coherent practice, but God, have we argued about it. And as a result, there are some patients who are going out where every patient with COVID in the ICU is getting full dose anticoagulation, whereas others of us are practicing where we only anticoagulate if a clot's found. I do not know what the right answer is. I wish I knew what the right answer is, but I don't. But what I do know is that it's really important that this be handed off into the outpatient setting in a coherent way. If a clot was found, there are ACCP guidelines that feel like they should be determinative precedent for how long and what level of intensity anticoagulation should be done. In contrast, if no clot was found, if this is purely empiric anticoagulation, that information also needs to be handed off, and there's got to be some plan for how long empiric anticoagulation should be. I don't know what it is, but I do know it's not fair to turf this to a primary care doc to have them go through 800 pages of note to try to figure out if there was a clot or not, to try to guess whether or not they should continue anticoagulation for how long. So in the dirty dozen, the first cluster is the meds cluster. The second cluster is the follow-up cluster. I think there are two important questions we need to ask in the follow-up cluster. The first is, what's the plan? Who should the patient call in the event a new issue arises prior to their first primary care provider visit? You all are a mission-driven healthcare system, which takes care of a lot of folks, many of whom do not already have connections to primary care. Who knows when their first primary care visit is? Even among those who care for patients whose patients do have primary care provider visits, often it's not going to be 2 or 3 days. The outpatient settings of many of our great systems are in shambles, and so there may be a substantial delay before the first primary care visit. And patients need to know who they can follow up with for the short-term problems that we know are so common at the best of times. We know what our readmission rates look like at the best of times, and we know these are not the best of times. Closely related to that is helping them understand what our priority of their follow-up is. Because follow-up is going to be really hard in the current environment, and they got to know what they got to do. Often you come out of a great system like Henry Ford of the University of Michigan with a list of 15, 17 different consultants who can see you to optimize this organ or that organ. Often we'll have discovered a bunch of incidentalomas. And so to tell a story from one of my colleagues who runs a post-ICU clinic, Jake McSparron, he had one of his patients show up, and Jake asked him what follow-up they'd gotten. And he said, oh, yeah, we booked the CT scan to follow up on this nodule in my kidney. Because I don't know what that is, doc, but I'm worried about cancer. And so 6 months from now, I'm definitely going to get that thing imaged to make sure I don't have cancer. And Jake said, that's great. Speaking of your kidneys, have you seen a nephrologist yet? And this is, I think, 5 days post-discharge, and the patient said, no, I haven't seen a nephrologist yet. Jake said, well, have you urinated yet? And they said, no, I haven't had to urinate at all. And they've been told to follow up with a nephrologist to get their dialysis set up. And they hadn't remembered that. That hadn't struck them, that hadn't been made clear to them that was very important. But they had remembered the follow-up CT scan for the incidentaloma they needed 6 months from now. So we know our patients don't always make the same priorities that we don't always pick the same priorities that we do. And it's really important they understand what the mission critical ones are, and frankly, that those be set up for them before they leave the hospital. Because many of our phone trees, it's not easy to navigate. I would ask for those of you who get your healthcare either in the system or have chosen not to get your own healthcare in the system, how often do you end up just emailing your colleague and asking if they would overbook you as opposed to trying to navigate the phone tree? That's certainly how my kids get in to see the primary care doc, and I get in to see my primary care doc, because I don't want to, I just don't want to deal with the call center. If we can't deal it, what are the odds that our patients can? So cluster 1 was meds. Cluster 2 was follow-up. Cluster 3 is lines and tubes. So this is some data from my colleague Vineet Chopra, where he did a survey a few years back. And what he did is he went and found every patient who was on various services who had a central venous catheter. And then he just went and asked their attending physicians, hey guys, does your patient have a central line? And what you can see there is pretty consistently, they didn't know the answer. The ICU, we were better. We knew about 13% of the central lines. In the non-ICU setting, they didn't know about, sorry, in the ICU setting, we knew about 87% of the central lines. We still missed 13. In the non-ICU setting, they knew about 75% of the lines. They still missed 1 in 4. And honestly, I've given Dr. Chopra and the hospitalist group a fair amount of good-natured grief about this over the years in a collegial way. And then I took over my service, and I was getting ready to sign it out at the end of last week. And Avni Kumar, who's an amazing fellow, I was letting her run rounds, and she was like, we're going to do the ICU checklist on every patient. I was like, all right, Avni, that's going to be pretty boring because I run a tight shift. And Avni's like, okay, Jack, that's fine. We're just going to run through this. And on the 4th patient, we were running through the ICU checklist, and I found out he had a femoral arterial line in. And I had examined that patient every day. I had thought thoroughly. Apparently, I did his abdomen, and I checked his thighs for edema, but I didn't go all the way up to his femoral crease. And so we took that line out like an hour later, and I felt pretty guilty. The reality is, particularly with COVID, right, we're not going in rooms as much. We're not doing nearly as much physical presence in rooms or physical examination. Our teams are working under higher burdens, and this is something they're going to skip. And particularly since I personally made that mistake myself, I am concerned about how many lines can get left in patients or nearly left in patients, to say nothing of temporary IVC filters and the other temporary devices we knew we didn't do a great job of taking out. And related to that, we need to send home a written list of all the lines, tubes, and drains patients had in the hospital. Uh, Most of our patients have a loved one who's sitting there with a little notebook scribing the entire time and learning how to do wound care and learning why everything was poked and why everything was prodded. Those patients, those loved ones, those caregivers have all been banned from the hospital. And so when folks go out, they need to know what their bumps and bruises and holes are from and which to look for healing and infection risk. And if there's a problem, if you give them a list of every place we've perforated the skin, it's going to be much, much easier for whatever doctor has to sort out what that went to and where it came from than if we just send them out going, oh, don't worry, they'll remember. I think we didn't do this very well in the pre-COVID era, and I think I just counted on spouses and caregivers to have sort of kept their informal notebooks. But since we banned them from the hospital, I think we need to send that information out instead. Fourth piece. So we talked about meds, we talked about follow-up, we talked about lines and tubes. Can they make it on their own? This part's going to be depressing. It's going to be depressing even relative to the other conversation. First question is, has occupational and physical therapy seen the patient? At least at my institutions, we tend to think about OT and PT in terms of placement and evaluation for readiness. Given the shambles that Southeast Michigan and frankly the rest of the country's post-acute care systems in, that's not the only thing they're going to do. Even if we wanted to get a lot of these people into SNFs or SARS, those beds don't exist right now. And frankly, a lot of our patients are going to turn them down because they are worried about infection risk. So PT and OT have a second crucial role, which is they're fantastic at teaching people and their caregivers how to adapt to new disability. I think we need to make sure that they're having plans for adaptation. So let me tell you, these folks' brains are often not going to be the same. An anecdote and a data point. The anecdote here is the MRI from Jim Jackson. This is a 49-year-old entrepreneur who came back to see Jim after she'd recovered from sepsis, about 3 months out, I believe. And Jim did his IQ testing and said, "Yeah, you got an IQ of 110, ma'am. You're doing great." And she said, "No, I used to have an IQ of 145 because I had an executive physical, and they actually, for some reason, maybe do that testing. So even apparently normal IQs could be a massive deficit." And again, I'm an intensivist. I don't read brain MRIs, but I'm pretty sure there's not supposed to be that much black space around the cauliflower here. If you look, there's a lot of generous sulci. Um, and literally there's data that people's brains shrink during sepsis. There's also disturbing data out of France that's in the little pull quote up there, which is of the COVID patients who'd been discharged, 15 of 45 had a dysexecutive syndrome consisting of inattention, disorientation, or poorly organized movements in response to command. Folks are going out with brains that do not work as well, and we need to make sure they have plans for adaptation, that we take that into account when we ask how much follow-up can they really arrange on their own. The second part is realizing the financial toxicity that was true for these patients before they went out. It's going to be even more true now. Can they pay for the follow-up they need? You and I all know that if you develop a plan that's really elegant for that hinges on them getting a medication they cannot afford, it does not matter whether or not you write the prescription for that medication. If they don't get it, you might as well not write it. So you've got to ask, given the rise in unemployment and the often already stingy insurance that patients had from their employer-based healthcare system beforehand, can they get the medication, the physical therapy, the equipment, and frankly, the basic food and shelter they need? This graph is the April unemployment claims that came out this morning. What you see there is the month-on-month jobs lost or gained in each previous month. The data goes back to about 1940. The biggest acute recession we'd ever had since 1940 was in the about 1948, where you can see there was a single month where almost 2 million jobs were lost. Last month in the United States, 20.5 million jobs were lost. That red bar that I have on this slide only goes down to 10 million. That's only half of the size of the graph, but in order to make the graph visible to you, I couldn't actually include the entire graph. It's an extraordinary level of consequent unemployment and dislocation going on. And we know that patients were having trouble already. This is some data that came out in Critical Care Medicine yesterday from Katie Hauschild, where she followed up patients with ARDS from the last PEDAL trial and talked to them about whether they were having financial problems. And they described poignantly and repeatedly how the inadequacies in their insurance combined with high copayment and the job losses and unemployment and dislocation from their jobs kept them from getting the care they need. One man said physical therapy was very short, a couple of weeks maybe, and then it was over and I just laid around basically. My insurance did not cover anymore, and so they had cut me off. Another described being unable to get to dialysis because they couldn't afford transport. I wonder with horror how many of my well-crafted follow-up plans never got executed because the bureaucracy and the barriers that so many insurance companies place prevented them from getting done. That's frustrating. Let's talk about the ways you can arm the patients to be able to help prevent some of these problems. And there are really a cluster of 3 things in the education component that you can do to help. The first piece is to remind your patients that they're going to have to push themselves to move and exercise. That fatigue is a ubiquitous component of recovering from acute hypoxic respiratory failure. And the advice that their mom gave them, which is why don't you just take it easy for a few more days, and then once you're feeling better, get back to exercise, is the wrong advice if you've been in an ICU for a couple weeks. Instead, I think the relevant advice is the advice we give obese patients about telling them that they need to push themselves. They should not immediately go out and run the Boston Marathon, but they need to get 20 to 30 minutes of exercise every day, try to get their heart rate up a little bit so they can gradually rebuild. This is some data from Zudin Puducherry that shows in the upper left corner the change in your cross-sectional area of your rectus femoris. And what you can see is within 3 days of people being mechanically ventilated, there is a significant and measurable decrement in the cross-section of their rectus femoris. By 7 days, it's over 10%. By 10 days, it's almost 20% of the rectus femoris is gone. At the bottom are biopsies. Day 1 looks like good normal muscle, right? I'm not a microbiologist, but even that looks like well-structured muscle. In contrast, by day 7, you can see the infiltration, you can see the loss of organization. It looks a lot more like ground beef than it does like steak. And what we see is our patients are getting weak, and they're not weak just because they're tired. They're also weak because they're literally lost muscle mass. And if they wait on the couch for that muscle mass to come back, it's never going to come back. Instead, we need to help them get moving again. Some of that'll be physical therapy. But given that we can't necessarily count on physical therapy, you need to get them and counsel them to get re-engaged in their lives in a coherent, slow, but insistent way. Second piece is have we educated them about the 5 most common things people are readmitted for. Those are newer recurrent infections, CHF exacerbations, acute kidney injuries, COPD exacerbations, and aspiration pneumonia. Our healthcare system, and frankly, people can self-manage a fair number of these things early on. And so we need to ask, is there a system in place for them to say, monitor their weight, for them to take their own temperature and respond early, potentially with more antibiotics for a potential fever, given that they're functionally immunosuppressed? Are they aware of the significance of coughing when they eat and knowing how early that they need to get an SLP evaluation? These big 5 from Hallie Prescott account for about 20% of all readmissions after sepsis. Um, and we don't have time for that. We've been too busy for the last few months to have our patients start coming back for preventable reasons. And then the last piece is remember that their brains don't work, they're overwhelmed, and they're getting to see their loved ones for the first time in days, sometimes weeks. And so they're honestly not going to remember what you have to say. So we need to prepare them a to-go packet that includes the information they're going to need. The American Thoracic Society has put together this very nice 2-pager that includes a testimonial from Susan East, who is an ARDS survivor, about what the post-intensive care syndrome is and how to try to get help. Because honestly, they're not going to hear you talking about cognitive impairment. They're going to hear, I get to go see my kids again. And that's wonderful. And they should be focused on that. But if in a couple months they find they can't remember their kids' names or that they're yelling at their spouse for no good reason, if you give them this information, it may be able to help them pull it together. At the same time, there may also be ways for them to help learn together about how to stay on the road to feeling better. Mari Pitcher, who's one of our social workers, is starting up a Zoom support group. She announced this morning, and I asked her, and she said she would be thrilled if folks from Henry Ford could join, and frankly, she'd be more than happy to start another group if there's enough demand. So if there are folks you think who are would benefit from being on a Zoom support group, by all means, please have them email Mari, and she'll get them screened and plugged in. So there's a lot going on. The post-intensive care syndrome's a big problem that has multifaceted aspects of it. There's a lot that you can't necessarily fix at discharge. Some of that damage is going to be done, but I think there are at least 12 things that I've tried to go over, thinking about meds, thinking about follow-up, thinking about lines and tubes, thinking about making sure they're primed to be able to make it on their own, and thinking about education that we could do to help give our patients the best possible shot. And with that, I'll end, and thank you for your attention, and I'm happy to take any questions.
Well, thank you very much, Dr. Washington. That was a really enlightening lecture. There were some questions that were asked by the audience, and I also have a question. So you mentioned about the medication being an issue in patients sometimes when they're discharged from the ICU. Is there any parameter that maybe can be followed or any guide that we can use to resume medications, for example, or, overall coming to an individualized care? Because I feel sometimes that, protocols are good, but pretty much protocols are good to make us remember things, but not necessarily to follow strictly and apply to everybody, because everybody's going to be a different person, everybody's a different patient with different issues.
Yeah, I think it's a great question, Javier. And I think the answer is we don't have enough data for protocols, but what we need to do is, I think, carefully and thoughtfully hand off to the floor teams what of our choices were empiric and what of our choices were based on transient physiology, and when were we instead stopping meds or starting meds because we intended them to be permanent. I think in the ICU, we tend to be, or I tend to be so focused on how I'm going to get through the next 6 hours. So I don't always think about the long-term implications, or put a lot of stuff into the, we'll sort that out later bin. By discharge, it's time for it to have been later. And so I think you need to just carefully say, we stop these meds, but they should be restarted as soon as safe. Say we stop these meds and they should never be restarted, and here's why. Or we started these meds and please stop them. We started these meds. This is what modern goal-directed therapy looks like. It's really embarrassing that they weren't on these beforehand. The group at the Glasgow Royal Infirmary, actually, whenever they write a medicine in the ICU for at least meds they start, they have to click whether it's intended to be temporary ICU only, temporary hospital only, or potentially permanent, to help make it easier to do med rec afterwards. Because I think it's just not fair to ask folks who haven't been in an ICU to wade through our pages and pages of notes to try to figure out what we were thinking about all these medication changes, and to distinguish which ones were intentional from which ones were unintentional. I worry they give us too much credit sometimes, and they assume that we're being thoughtful about things that sometimes I haven't had time to be as thoughtful as I'd like. Thanks, Javier.
Thank you. And that was another question actually from the audience. Um, Pretty much you kind of answered. It was about how can we do a better documentation of the important information when transferring the patient of the ICU, and having this balance between enough information versus too much and overwhelming the team who receives the patient in general.
Yeah, Tim Hofer, one of my colleagues on the hospital medicine, once walked into me and said, Jack, I just got another 5 patients out of the ICU. I need you to promise me in your last note, you're just going to write one thing and one thing only. In the end, the final ICU diagnosis was, because I get these 5-page transfer notes to tell me every time their PEEP and their Levophed was titrated, but at the end, I can't tell why they were in the ICU. So will you please just tell me why they were in the ICU? Right, that often documentation sucks. And so we let whoever the most junior person on the team, let that person do it. And so they tend to be travel logs as opposed to kind of a quick final summary. Often it would take no more than a paragraph to say, in sum, here's what I think happened to the patient. Here were their major complications. Here are the things we changed. And I think that little attending to attending handoff could be extraordinarily valuable.
Yeah, and you're right. And the same thing, we just got a comment from one of our antimicrobial stewards, pretty much just giving us sort of like try to give a better discharge instructions in terms of the use of antimicrobials and for how long they're going to need to be used, etc. Uh, that's also something that definitely should go with that. So, Jack, I have a question. Um, so, how do you feel about patients who are discharged from the ICU to other facilities rather than going to the GPU or the floor, to continue recovery? How do you see the role of these facilities when they actually get discharged from those facilities, or out tax facilities, for example, to home or wherever they go? What do you see the role for them in terms of this? I mean, they probably need to be educated about this as well, because they are going to be pretty much doing the job for us and for weeks or probably months.
Yeah, so I think so yes, it would be great. And honestly, I'd be more than happy to go give them this talk too. If your LTAC group wants to talk with me. The reality is I think we can, yes, ideally a system would solve all this. On the other hand, they in some sense, we are outside hospital to those hospitals. And if you think about the typical documentation that outside hospitals sends your transfers in, I worry that we're doing more or less the same thing to these LTACs, and that we're not giving them a sufficiently coherent, um, intelligent story that summarizes how thoughtful you guys have been and how thoughtful my team has been about these, because writing it up afterwards doesn't feel like it's worth it, and they need it. And so I think we've got to help them. We can't just hope that they'll sort it out later. But ideally, yes, this would coherent information transfer to help people make sense. This would be great. Thanks, Javier.
Yeah, no,
Great
thank you.
question.
um, there's a question here. It says, who should take ownership of PICS management both after ICU discharge and on the outpatient side if we think of this adverse effect of a procedure? um,
I mean, I think honestly, they don't let me rearrange the healthcare system. If they
right.
would give me full control of all 18% of our GDP we spend on healthcare, I'm sure I could spend it better. And I'm sure I would not be quite so worried about how I was going to pay for my kids' college. Um, but they don't. So I think again, this is one of those places where you don't want to let perfect be the enemy of the good. I think the answer is anybody who's willing to do it should do it, and we should find a way for them to contribute. Um, one of the things a group called the Critical and Acute Illness Recovery Organization, CAIRO, had been getting started building on some work done by the Society of Critical Care Medicine, is building a cluster of post-ICU clinics that are willing to work together. I actually think there's a foundational role for intensivists in this. Not every intensivist needs to do this any more than every intensivist needs to be an ECMO specialist. But I think some intensivists from most groups need to step forward and become really interested in the question of how we develop a structured follow-up clinic. Jake McSparron's been leading that here, that sees many patients at about 14 days post-ICU discharge, wherever they are, and sort of does a cleanup run, goes through and tries to figure out What are their meds we didn't mean to stop? What are the other, right, kind of avoids the errors component, does things like collects the people who hadn't been seen by dialysis yet, but definitely need dialysis, and make sure there's a coherent handoff. I don't think we want to be in the business of being primary care docs, but I don't think it's fair to ask a primary care doc who hasn't rounded in the ICU in 2, 3, maybe 20 years to be able to make sense of what I mean when I say someone's on APRV. I think we need to make sure we have some intensivists who are willing to be that kind of translational specialists. And for us, that means um, having an intensivist, having a pharmacist do a full medication review, and having a social worker who's willing to help through both the cognitive emotional components of this and think about benefits and getting people connected to the right benefits. And we found that that seems to be enormously rewarding, and I think there's even more demand for that now.
Thank you very much, Jack. One last question I see here is about, is there any instruction or guidance that you guys give to your patients, for example, when they get discharged on and we still require oxygen, in terms of how they're going to be follow up, or what will be their evaluation?
Yeah, there is no there. That's just it's embarrassing, right? Like I say, I have to say this out loud to my colleagues here. I don't really know how that happens. At the VA where I practice, yeah, because we're stingy with oxygen prescriptions, there's a very nice structured system in place to basically reevaluate patients every couple months to make sure they still need oxygen, but then also to make sure the veterans who need it are getting it. At the U, folks who are in the system and are sort of owned by the system have some follow-up, but a lot of folks are just left to their primary care doc to negotiate this. And I mean, it's oxygen. For the love of God, I don't even follow up their oxygen necessarily. Um, and that's just horrifying to me. We don't have a great system in place, and it's just another sign of how, in some ways, broken our healthcare system is and how much work we need to do to find ways to sort that out. And again, another thing, it just doesn't feel fair to a primary care doc to try to figure out what their outpatient BiPAP regimen for their obesity hypoventilation syndrome should be, right? Like we've got to be able to help do some of this bridging for them.
I see. Yes, you're right about that. Unfortunately, there's no such a thing yet, and hopefully, as we advance and we continue to develop all this with the guidelines and with from people like you, for example, that are interested and do a lot of research on this, can probably help us do better in general. So, is there any other last comment that you would like to add on, Jack, just to close before we
Um, I,
close?
one is just to send out a genuine open invitation for continuing this conversation with folks. That if this feels like we're at a very important historical moment where COVID has meant people have actually heard about acute respiratory distress syndrome in a way that they never had anymore. That Merriam-Webster means that we can tell the difference between an intensivist and an ER doc. And I'm not sure, frankly, until COVID happened, that my brother could actually knew that I wasn't an ED doc. Not that ED is not noble; it's just a different thing. Um, and that there's a room for research in this, but I think there's also a room for practitioners who want to say, we're going to walk with these patients and we're going to walk together and try to find better ways to do this in the way that great doctors have always done that. And I hope that there'll be opportunities for us to work together to discover what our patients need and how to make it work. But thank you so much for your time. I really appreciate it. And do please shoot me an email or shoot me a tweet if you want to follow up.
Thank you. We definitely will. We would like to thank Dr. Iwashina for such a great lecture and for taking the time during this difficult time that we are all experiencing as part of the healthcare force to educate us. I definitely believe that the points discussed today could be applied to our current ICU practice. Thank you very much to the audience too for sticking with us, and thank you very much. Thank you, Jack, for everything.
Thanks, guys. And if we're ever allowed to travel again, I can't wait to come down and visit you and see some of you in person.
Oh, perfect. We'll do that. We'll set it up. Thank you.
Thank you.
Thank you. Bye.